Welcome to the 15th PhenoTips Speaker Series. We're once again joined by a panel of exciting guests, where today we'll discuss the topic of whole genome sequencing and how to navigate it in the clinic. The speaker series is brought to you by PhenoTips, the world's first genomic health record system, a software and service that makes genetics professionals' workflows easy and intuitive. PhenoTips incorporates features such as pedigree drawing, standardized symptom capture using the human phenotype ontology, and insights such as differential diagnosis and gene suggestions. Since electronic health records aren't built for genetics, PhenoTips fills the gaps by providing a complete suite for genetic medicine. In light of the pandemic, PhenoTips is sponsoring this speaker series. I'm your host, Dr. Paweł Buczkowicz. I am the COO and VP of Scientific and Medical Affairs at PhenoTips, and my main focus and passion relates to improving genetics workflows in the clinic. I have Lean Six Sigma certification and a PhD in cancer genetics and molecular pathology from the University of Toronto. My research interests focused on using next generation sequencing technologies for improving therapies for high-risk childhood cancers, developing and validating clinical genetic tests, and translational research projects focusing on things such as pediatric stroke, central nervous system vasculitis, and pediatric brain tumors. The dream of precision medicine, or more specifically genomic medicine, is fundamentally based on the relationship between the genome, the variants in the DNA, and the way in which those variations are expressed in the environment in which we find ourselves. In the context of medicine, this could mean the presence of phenotypes or symptoms of a particular genetic disease, so especially in the rare disease context. It could mean a variant's role in determining the efficacy or side effects of a particular medication, such as pharmacogenetics. The methods by which genetic variation is examined in the context of health and disease can change over time. Progress on various technological fronts has provided us with many tools, techniques, and assays to utilize it as part of this diagnostic endeavor. Sort of none more revolutionary and broadly applicable as whole genome sequencing. We're still in a lot of ways in the early days of adopting whole genome sequencing in the clinic, and today we'll be discussing the experiences of our three guest panelists, Dr. Olaf Bodamer from Boston Children's, Dr. Ian Krantz from Children's Hospital of Philadelphia, and Dr. Austin Larson from Children's Hospital of Colorado. We'll soon give each of our panelists a chance to introduce themselves, but first we'll do a little bit of housekeeping around the format of the webinar. We'll start off with about a 15-minute discussion with our guests, followed by a 20-minute question period, where we will be taking questions from you, the audience. You'll be able to submit your questions throughout the discussion in the Zoom's Q&A box, and we'll try to take up as many of those questions as we can in those last 20 minutes. I'll now ask each of you to introduce yourselves, and perhaps, beyond your affiliations, you can also let me and the audience know where your current focus or research interests lie. Maybe Dr. Bodamer, you can go first.
Yeah, thank you, Pavel, and thank you very much for the kind invitation to join this distinguished panel. My name is Olaf Bodamer. I'm a clinical and biochemical geneticist at Boston Children's Hospital and the Associate Chief for Clinical Genetics and Genomics. I'm, from a scientific standpoint, interested in disorders of histone modification, particularly Kaposi syndrome and others. And I'm also interested in the utilization of innovative therapies for rare diseases. But most importantly, one of my passions lies with looking into ways to shorten the diagnostic odyssey, and most importantly, shorten the time to treatment for individuals with rare diseases. So thank you again for having me on this panel.
Thank you for joining us. Dr. Krantz?
Yeah, thank you. It's a pleasure to be part of this panel as well. So I'm Ian Krantz. I'm a medical geneticist, pediatrician at Children's Hospital of Philadelphia. My evolution into this sort of world of genomic medicine really started similar to Dr. Bodamer interested in rare diagnoses and applying new genomic technologies to try to find answers and discover novel genes for those diagnoses. And it quickly became apparent that those tools were going to have a huge impact on what we do clinically. So we got very involved in early on in studying the applications of genome sequencing in the clinical setting, and that eventually led to the establishment of the Roberts Individualized Medical Genetics Center here at CHOP now 7 years ago, which really was set up to help facilitate genomic level testing across the institution and across all specialties. Because as we developed these new broad-based tools, it became readily apparent that these were going to apply to patients that were beyond what we classically saw in genetics, but apply to almost all patients. And there needed to be a way to help navigate both educating and consenting patients and undertaking the testing, interpreting the results, and returning those results to the patient. So I've transitioned from a lot of the basic research focus to much more clinical focus. And that's, I guess, where my connection is with this panel currently.
Thank you. Dr. Larson?
So my name is Austin Larson. I'm a pediatrician, medical geneticist, biochemical geneticist. I have been involved in the implementation of whole genome sequencing here at our institution for about 4 years. And in addition to that aspect of my practice, I participated in a number of trials of therapies for rare diseases. I'm involved in some national consortiums for mitochondrial disorders and disorders of glycosylation, both of which are commonly diagnosed on whole genome sequencing. And then a couple lenses that I'll mention that I look at this through are that I do a fair amount of rural outreach, and I'm a big believer in the impact of whole genome sequencing as it relates to outreach to settings that have fewer medical resources. And I'm also the program director for the clinical genetics residency and associate program director for the medical biochemical genetics fellowship. And so I think a lot about how to implement education around using whole genome sequencing for our trainees.
Excellent. Well, I'm really excited to jump in to the topics. It seems like we have a very experienced group of panelists today. Setting the stage, maybe Dr. Larson, you can kick us off. What, in your experience, is the typical patient journey look like from referral to that test order? And could you walk us through that process and tell us a little bit about at what point that genetic testing decision is being made?
So this looks very different. This is changing a lot in the last couple of years. So I think in the past, the role of genetics was viewed as someone to come in after the fact, after the patient's phenotype has kind of declared itself, after they've become kind of differentiated and they have clear aspects of a specific clinical syndrome. And then the role of the geneticist was to make a clinical diagnosis and send a targeted genetic test as a confirmatory test for that clinical diagnosis. So that was the old paradigm, and that paradigm really led to this phenomenon that we've all talked about of the diagnostic odyssey, which is that the patient has to progress further and further in their illness. They have to get more and more expert input. They have to get more and more invasive and expensive phenotyping, whether that's imaging or biochemistry or functional studies. And then at the end of the line, the geneticist can come along and say, this is why all these things have already happened. And that has changed a lot recently for the better, which is that the geneticist can get involved at a much earlier stage in the process when the patient has a phenotype that is more undifferentiated. And the importance there of an undifferentiated phenotype is that in some cases means that there's more opportunity for intervention prior to kind of irreversible injury having happened. But the consequence of being involved at an undifferentiated state is that it's often impossible to make a clinical diagnosis, and we rely on hypothesis-free genetic testing, broad genetic testing, to give us the sensitivity to be able to make an accurate diagnosis for a patient with a relatively undifferentiated phenotype. And as geneticists, we much more often are involved at the early stages, and the genetic diagnosis then is used in really high stakes medical decision making going forward. So it's almost completely flipped in terms of what I see from my colleagues, from them asking us to get involved at the end of the process and explain what happened, to now them asking us to get involved at the beginning of the process and help them to find an accurate diagnosis that will assist with medical decision making going forward.
Dr. Krantz, is that your experience as well? And how much would you say, I guess, the increased use of whole genome sequencing has sort of led to that flip?
Yeah, I think that's kind of been the trend, definitely. And it's gone from, when you think about exome and genome sequencing, it was kind of the big guns that were at the end of usually a long process, to now becoming a frontline test more and more. And the issues we face at our institution are more that many specialists, people who practice in cardiology and rheumatology and gastroenterology and immunology, want to use these tests. And the reason for setting up a program like we have here at CHOP to help facilitate that was really to help navigate that process, because it's complex and it's burdensome financially sometimes for the families or the institution. And then often when test results come back, the people who ordered them, if they don't have the expertise, don't really understand them, and there's a lot of misinformation. So, patients come from all different aspects now, not classically through genetics, but they're coming from different specialists. There are, inpatient issues that are different from outpatient issues and the pathway that they take. But I think this has been really a revolution for our trainees. We sort of say that they're living in the era of genomic medicine now, which is really what this period is going to be known as, but accomplishing, getting the testing and using it in a meaningful way is challenging. But again, I do see us as Dr. Larson said, we're not at the end of the process after someone's seen 30 specialists and someone says, oh, maybe there's a link between all of this, let's send them to genetics. We're more approached at the very front of the process when a child presents with dysmotility or isolated periodic fevers or isolated epilepsy. And it's very exciting because we as geneticists are having to become generalists again. But it's different between the physicians and patients who want the testing, and then obtaining the testing is a whole big leap.
Dr. Bodamer, do you have any comments on that as well?
Yeah, absolutely. I think we see a similar trend to earlier referrals, but on the other hand, we also still see patients who have been seen by multiple specialists, and clearly diagnosis was significantly delayed in still a good percentage of the patients that come to our clinical practice. I would argue that it's still very important that we kind of look back to our roots, the roots of medical genetics, and we think about our talents. And I think what's really important, even in the advent of whole genome sequencing, is an in-depth assessment of the patient's past medical history, family history. And I cannot really overstate the importance of clinical phenotyping, which should be precise and detailed. We should recognize the need to state pertinent negative findings and really synthesize that. And that's what I convey to our trainees, to think about differential diagnosis. And while there is certainly a case to be made for a large number of patients to undergo exome and genome sequencing, there are still patients who they come to the clinic and you have a clinical diagnosis. Obviously, trisomy 21 is the obvious example, Kaposi syndrome. I mean, there are a couple of other genetic syndromes where I still feel comfortable to do a single gene or at least a small gene panel. And then you have another group of patients who come in with a positive biomarker, so metabolic patients, for example, newborn screening recalls. There's a biomarker that actually gives you a good differential and allows us to do a single gene or a small gene panel. And then you also have a group of patients where there is a single finding, retinitis pigmentosa, for example, or cardiomyopathy without any associated clinical features. And in these cases, I still feel comfortable to order a gene panel. And then, of course, you have all the other patients, I think we all know, complex neurological phenotypes in association with other findings. Obviously, they make a very strong argument for whole exome sequencing or whole genome sequencing. The other thing I want to point out, we see about 5% of cases who have two independent monogenic conditions, and they would go undiagnosed if we wouldn't use exome or genome sequencing.
Yeah, that's actually really good insights, and sort of, I guess, brings me to sort of the next question. Dr. Larson, perhaps I'll take it, sort of let you take this first. How do you evaluate what should be the first tier genetic test? Sort of what percentage right now, in your experience, is whole genome sequencing, and what percentage of those tests, first tier genetic tests, should be whole genome sequencing, if everything was sort of set up to its optimal efficiency, reimbursement, etc.
Yeah. I guess my kind of philosophical approach is the question of, am I more likely to miss a diagnosis by not testing broadly enough or not testing deeply enough? So to give you an example, we had what you could consider a false negative whole genome test recently on a child with seizures, and then a targeted seizure panel had enough read depth to call low-level mosaicism for a diagnostic finding. So whole genome is not always the perfect test. The ability of the whole genome to go deeper, so to detect things like SMA, myotonic dystrophy repeats, things like that, is improving. So, kudos to those folks that are working on the analytical side, on the chemistry side, in terms of increasing the sensitivity of whole genome sequencing for a broader and broader variety of mechanisms. But until we get to the point, where it truly encompasses even more mechanisms, as Dr. Bodamer and Dr. Krantz made the point, it's critical to bring our medical genetics training to bear on the question of what is the likely mechanism here. And so for a patient with a very specific and very differentiated phenotype, we may be better off doing a more targeted test, especially if there are atypical mechanisms at play. But for a kind of relatively undifferentiated patient, relatively earlier in their disease course, in my mind, we are more likely to miss a diagnosis by going deep than by going broad. So what the most important thing earlier on and in a more undifferentiated state is that breadth. So I don't know if I have exact answers for you of how often whole genome should be the first tier test. I can tell you that I would like to do it more often than I am now, and the limitations are more kind of financial and logistical than they are in an intentional decision to not do whole genome.
Mm-hmm. And those things will likely evolve over time, as well as genome and analysis costs and computation decreases over time, as it has been quite significantly over the last, even just last few years. Dr. Krantz, in your experience, how much say do you think a patient typically has in sort of the type of genetic test that's being selected? And do you see sort of an impact on the patient experience depending on the type of test, whether it is whole genome or a more targeted panel or a single gene test?
Yeah, well, it's a complicated question because it obviously depends on the level of sophistication of the patient and their family and the amount of education that they're given about the testing options. You know, we are big proponents of sort of the right test for the right patient at the right time philosophy, even though we have a definite genomics tilt. Sometimes it's the complexity of the test. So obviously, you know, panels have advantages, as was mentioned, in terms of maybe quicker turnaround times, maybe less expensive. There may be specific quirks about the genes being tested that are better addressed on a panel than on a whole genome. But one of the big issues is all of the data that comes back on a whole exome or genome sequence, and secondary findings and incidental findings and variants of uncertain significance that sometimes are very distressing to families. And so the approach really needs to be geared towards the families and their understanding of the test and what, you know, they're able to cope with. So we definitely would not do a test without a family's approval. For exomes and genomes, for the most part, we do need consent from the families because of issues of secondary and incidental findings. So at least they're being educated. But for many of our other tests, you don't even need to ask permission of the family. If it's an inpatient in the ICU and you want to do a cardiomyopathy panel, it just goes in as an order. But I think it is important to discuss with the family what their expectations are.
Dr. Bodamer, what have been your experiences with that?
I think our experience has been overall positive. You know, families tend to follow our recommendations for genetic testing. We had very few, if any, families, you know, not follow our recommendations. It's interesting. We see an association between disease burden in the patient and length of the diagnostic odyssey, and those families tend to ask actually for the more comprehensive genetic testing, exome and genome testing. Some families, you know, have concerns about what Dr. Krantz just mentioned about, you know, incidental findings and variants of uncertain significance. But they also understand that there is an important advantage to exome and genome because there is an opportunity for reanalysis as time goes by if there are negative findings. And that's important to many families. It's almost like they have an ongoing test at regular intervals.
Dr. Larson, you also mentioned running an outreach program from your clinic. How does that sort of, are there differences between patients that are actually seen and referred to the hospital itself versus the outreach program that you run?
Yeah, I really think of it as a question of equity of access to specialty care. And, you know, we've already touched on the importance of experience and expertise in this field, but that can be a big barrier. The need to either travel to where an expert is, or the truly expert folks are few and far between, and it's hard to get into their clinics. It's hard to be seen by those people. It's also hard to know ahead of time who is the right expert to see you and to have that clinical insight that can, you know, make that clinical diagnosis that was missed elsewhere. So I do think of whole genome and whole exome sequencing as kind of a safety net and an equity issue in some ways, that those patients that don't have the ability to travel outside of their area, or who have, you know, a year-long or 2-year-long wait to get in to see someone in a genetics clinic, or, you know, a specialist that has the experience to be able to make a difficult clinical diagnosis. I see broad testing as being kind of a safety net and identifying a lot of rare diseases in people who otherwise would have been missed. So that's something that I feel strongly about in terms of access to care and kind of equity of people in different geographical areas being able to get diagnosed.
Yeah, that's a very interesting take on it, and I think 100% agree about the use of broad testing and at least bringing equity to some of that genetic testing access. Very interesting. So the ACMG has recently published guidelines on using exome and genome sequencing as a first tier or second tier test for patients with intellectual disability, developmental delay, or congenital anomalies. What are your thoughts, or what would other indications be where first tier testing should be used? Perhaps in the next the next phase. Maybe Dr. Krantz, you can start off.
Sure, I'll take a stab at that. I mean, those are pretty sort of advanced recommendations that came out, because it isn't standard practice for a child with an isolated birth defect necessarily to get an exome. It's definitely not always accepted by the payers to support that approach, but I think it is a valid approach. I think there are more and more using exomes and genomes as a frontline test makes more sense as we're able to detect copy number on those tests, as we're able on genomes to detect trinucleotide repeats. There are obviously some mechanisms that are not detectable that might require focused testing. But I think for almost any indication beyond those, I would say a neonate with seizures would be an indication for pursuing this type of testing. There's a whole slew of test recommendations that would fit into this guideline, but may have to be adapted. So I think even in the prenatal setting, an exome or a genome could be adapted to look at things that don't cause too much distress. You can do the analysis in a way that looks at sort of a subset of genes or a panel or an exome within a genome, and that can be adapted depending on the diagnosis, depending on the age of the patient, and what you're looking for. So there are very few scenarios, as cost is coming down, as our analytic capabilities are improving, as the uncertainty is decreasing as we do more and more of these tests. There are very few indications where a patient who needs genetic testing likely wouldn't benefit from this type of approach, with the exception of cases like Dr. Bodamer was saying. Clearly, if you know a specific diagnosis and you can do a targeted test, or you think a child has Prader-Willi syndrome and you want to do a methylation test rather than a DNA sequencing test, there are exceptions to that. But I think that this type of testing has very broad applications, even beyond what the ACMG are acknowledging at this point.
Mm. Dr. Bodamer, would you like to comment on that as well?
Yeah, let me expand on that. I think there's a growing body on the utility of whole exome sequencing, whole genome sequencing in the NICU setting using a rapid approach. And when you look at the data that have been published, I think it's pretty convincing that there is utility that changes management and sometimes redirects care. There is also growing evidence for utility of first-tier exome sequencing and genome sequencing in a critically ill, pediatric intensive care unit setting. And I was always wondering whether we should also start thinking about all our transplant patients. I mean, there is ongoing liver transplant in patients where there is idiopathic liver failure. And we had experienced a case, this was a newborn with idiopathic liver failure, who then was put on the transplant list, but after doing a rapid whole exome turned out to have Niemann-Pick type C, and care was redirected at the time. Another interesting experience in our hospital was a child who was referred from outside for a bone marrow transplant due to some idiopathic form of immune deficiency. Again, we did rapid whole exome and identified hereditary orotic aciduria, which is a very treatable condition, and it actually alleviated the need for the bone marrow transplant. So I think these are two examples, but I think we should really expand our, the indications for whole exome and whole genome sequencing, and also kind of think about those populations.
Dr. Larson?
Yeah, I would say another kind of spin, in addition, I totally agree with the prior comments. One other take on this is the question of whether the phenotype for which a patient is referred, is that a primary phenotype or a secondary phenotype? And so primary care physicians who are taking care of children are very attuned to developmental milestones, and they're very attuned to atypical growth. And sometimes those things are a primary phenotype. So a patient with atypical development has a disorder of the embryological development of the brain. Or sometimes that's a secondary phenotype. So a patient with atypical development might actually have chronic anemia, or something that you just never would have thought of. And so I think that possibility that these kind of general indications for referral are actually secondary phenotypes, that's an important argument for really casting a broad net with your initial diagnostic evaluation.
How do you see how do you see whole genome sequencing perhaps gaining more traction outside of the traditional genetic space in the hospital, and sort of out to primary care and pediatric developmental pediatricians and others to actually order those tests ahead of time and sort of bring the genetic specialist to analyze those once those maybe phenotypes and symptoms and other things become more indicative of a diagnosis later on?
So I think that's going to have to happen, right? There's just not, we just don't have the genetic professional workforce to be able to implement this as broadly as I think it could be. And so it's on us, and it's on the labs that are doing the testing to make this test palatable for other people. And so in a couple ways, so for the labs, different labs, and this has been discussed previously, but different labs have different approaches to reporting variants. And some labs optimize their test for positive predictive value, and other labs optimize their test for sensitivity at the expense of positive predictive value. And so that higher positive predictive value test is more appropriate for a developmental pediatrician, a primary care pediatrician. That kind of optimization for sensitivity is probably more appropriate for a genetics clinic. And so, there are different approaches to the analysis that can make the test more appropriate for different clinical contexts.
I have a follow-up question for you there, but I think I'll leave it for a little bit later because it might lead us into a little bit of a different topic. Dr. Krantz, maybe we'll go back to basics and kind of ask a very interesting question. What is the actual process for ordering the whole genome sequencing? How do you navigate all the associated paperwork, the various parties involved, laboratories, payers, perhaps healthcare system? Do you have any advice for our viewers, for those who might be at institutions who are maybe just implementing and rolling out whole genome sequencing in their clinics?
Sure. Well, let's say ordering genome sequencing is really easy. Getting it reimbursed is the problem, and not bankrupting your families or your institutions. And different institutions have different hoops that you have to go through to get the testing order. We deal, one of the main focuses of our program here, the Individualized Medical Genetics Center, is to sort of centralize that process to navigate through approvals and getting the testing hopefully performed on the families in different ways. So that involves getting pre-authorizations. There are different pathways for inpatient versus outpatient, but for outpatients, we'll never order these tests without getting pre-approval from the payer in advance. And that often requires writing letters of medical necessity, doing peer-to-peers when they're denied, to fight for approval. If they're not approved, there are certain companies that will do exome and genome sequencing and do benefit investigations for families to tell them exactly what it would cost out of pocket. And in many cases, there might not be any cost to families. You have to be, even when a test gets approved, you have to be cognizant of what copays there are depending on the insurance the families have, because a test that might cost $12,000 or $14,000, if there's a $2,000 or $3,000 copay, that could be insurmountable for some families. So it's a huge morass to navigate. It's getting mildly easier with some payers who are starting to recognize these tests as standard of care, starting to recognize that doing an exome is more cost effective than doing chromosomes and arrays and single genes and panels, and getting it all done up front, both in terms of maybe diminished costs for the actual testing, but also in terms of finding an answer earlier and instituting more targeted treatment. So it's really quite complicated. And although many clinicians want these tests, many of them aren't comfortable navigating this front end part. So many institutions have set up programs that help that navigation.
Has the reimbursement process evolved over the last few years? Has it become simpler, or is it still difficult to navigate?
Still, I'll say it's still complicated, although I've developed really fond relationships with a lot of the peer-to-peer reviewers who I talk to multiple times a week. We tend to talk about our kids, and then they tell us, oh, well, it's not approved at the end anyway. So, but it is getting slightly better, and statements like what came out of the ACMG this year and other studies that are showing these tests to be standard of care give us more tools to argue that, and eventually the policies at the payers will change and make that easier.
Right. We're just hoping we get there faster than sooner than later. Dr. Bodamer, would you like to comment on either of those?
Yeah, that's like a hornet's nest here. I second what Dr. Krantz said. I think the key is to centralize the process within an institution. And we started doing that in genetics and genomics, and kind of take really baby steps to also involve the other specialties. And I think the other key aspect is to partner with one genetic testing laboratory that would, as Dr. Krantz stated, would do the benefits investigation, and prior authorization would fall on us. But I think I'm still intrigued by how much time and effort it takes to get and we're not talking about genomes, exomes approved and the patients tested. I think this is time not necessarily well spent, because it takes us away from other activities. And I'm not quite sure that the payers truly understand and appreciate how much effort that takes. And at the end, I would say in most cases, it actually gets approved. So the question to me and to the panel would be, is there an opportunity for the institutions to band together and approach the payers at some point, highlighting the needs for, I think, a reform of the current, approval process for exome and, of course, genome.
And in the US, would that be on a state-by-state level, or could it be done sort of nationally?
I think there obviously the state-by-state plays an important role, but I think there could also be a national approach. And I'm always wondering whether there is an opportunity for us to create a database that would house all the information in a central place, with acknowledging the state-by-state variation, and really start talking to the payers about streamlining their processes.
Dr. Larson, any comments on that?
I'll just say, one thing that I would love to see, to those of you out there who maybe have influence with payers or health systems in terms of how these things are approached, is that, when I see a patient that gets referred to cardiology, that referral to the cardiology clinic includes approval of an echocardiogram and an EKG. And getting genetic testing is analogous. In terms of a referral to a genetics clinic, it feels to me like that should include approval of the testing that the geneticist will inevitably need to do in order to care for that patient. So I would love to see that. I haven't seen that yet, but I think that would be a nice approach.
Dr. Bodamer, in terms of, so when it comes to analysis of the test results from whole genome sequencing, or interpreting the results that come back, what are the biggest challenges that you think exist for the geneticists today?
I think the biggest challenge is obviously putting the variants of uncertain significance that are frequently identified into that clinical context. And it becomes challenging if there is essentially no body of evidence or information available that would allow us to interrogate those variants in a clinical setting. I think there are some good resources out there. There's obviously GeneMetry as one example, that allows us to exchange information. I would kind of, again, on my endless wish list is some common phenotype database that would be linked to that variant or that gene even, that would allow us at least some more in-depth evaluation of the variant of uncertain significance. But yeah, I think that's what I see as the biggest challenge. And then I think the other challenge is to obviously have the family understand that that variant of uncertain significance might not necessarily imply a molecular diagnosis, and that might actually take some time until further information becomes available that allows reinterpretation of that variant.
How often do you see VUSs coming back from whole genome sequencing, and what is your approach with discussing that with patients and families?
So since we are doing very few whole genomes, I kind of answer that based on our exome experience, and I think I would say it's probably every other exome, if not 2/3 of all exomes have variants of uncertain significance. I usually spend, together with the genetic counselor, quite some time during the pre-test counseling to explain, what is a genetic variant, what types of genetic variants are there, and what criteria are utilized to interpret the variant as either benign, pathogenic, or uncertain, and take that information from the pre-test counseling and do the post-test counseling accordingly. And I think the families, for the most part, they understand the concept, again, depending on education level, and they really appreciate that, genetic counselors in particular take their time to explain that concept.
And I want to just make clear, so everyone understands, that VUSs aren't only the domain of exome and genome sequencing, but many of the large-scale panels that we run, we have more VUSs back than definitive answers.
Absolutely.
So what steps can be taken to better classify those variants of unknown significance? Sort of what support do the medical practitioners and bioinformaticians and others need to enable that classification to be updated more readily?
Yeah, well, I think it comes back to what Dr. Bodamer kind of alluded to, is having some kind of centralized databases. So I think it's clearly been shown, as the volumes of these type of testing go up and we share that data, the better equipped we are to understand variation and understand, what's pathogenic and what's not. So a lot of the sort of uncertainty, which is kind of one of the complexities of doing this level of testing, has definitely improved over time. But I think, if we could ideally have sort of a national database where all clinical exome and genome sequences get submitted with good phenotyping, so we understand the clinical picture, it would bring us a long way towards diminishing, or let's say improving our understanding of VUSs and diminishing the anxiety that causes to clinicians and families.
How do you see the role of phenotypic information? Sort of what role do you see phenotypic information playing over the coming years as maybe these sorts of databases and systems are built out?
Yeah, I'll just comment briefly. I think phenotyping is always the Achilles tendon of any large genome studies or clinical usage. And I think we need to get away from billing codes for phenotypes and get more into really descriptive detail codes, much like you mentioned for PhenoTips, using sort of an HPO type ontology, but it needs to be harmonized, across institutions, so that we're all talking in the same language. And those phenotyping terms should be targeted towards understanding the genotype and not, maximizing billing.
Right. I have a question which I'd like to ask all of you, but I'll start with Dr. Larson. So ultimately, the judgment call that sort of concludes the medical applicability of a variant, regardless of the report that comes back and the variant classification that comes from the laboratory, is the responsibility of the clinician. how difficult is it to deal with some level of unknown and ambiguity when it comes to making that call?
It's pretty difficult. I mean, there's I think a minority of people who can sort of think probabilistically, and most people have a pretty binary thought process. So, if you have a pathogenic variant, it's clearly black and white. It says pathogenic variant. It's well documented. But maybe the penetrance of that pathogenic variant is only 5% before age 40. So, you're talking with the family of a 5-year-old about a 5% penetrance over the next 4 decades. So, that sort of thing is really where the complexity comes in. And I think increasingly that's the value of clinical genetics is, on that end of the process, not on the test ordering side. And you talked earlier about maybe that test ordering actually moves and becomes more diffuse. But that interpretation, the ability to take that very nuanced point about the age-dependent penetrance and the environmental factors that are relevant and all those kinds of things, and to kind of package that in a way that's useful for the family and useful for the other providers caring for a patient, I really think that that's where we're going to increasingly be, that's going to be the value that we add going forward as medical geneticists.
Dr. Bodamer?
Yeah, I completely agree. I think the biggest challenge, I think the example you mentioned with the reduced penetrance, I mean, there are other situations where you have a level of mosaicism and changes in expressivity of clinical features in addition to the penetrance, and that on top of the variant being a variant of uncertain significance. I think in many situations it's close to impossible to really relay that back to the family in a way that they see the utility, and that they take their personal, that they take a personal takeaway from it. I think that's I mean, I would actually argue it's not only difficult in some situations, in most situations it's actually impossible.
Dr. Krantz, any thoughts on that?
Yeah, I mean, this is a huge educational initiative for clinicians, because we were very surprised in our program here where we facilitate genetic testing, we evaluate patients, we do consenting, we educate families. We assumed that the clinicians who requested the testing would be really comfortable returning results. We were surprised to find that they aren't, both because of VUSs and some complex results, but even a pathogenic result is complicated. Why is it pathogenic? Do they understand conservation of an amino acid? Do they understand the terminology? And it's clear that they really don't. So I think there's going to have to be a big educational initiative as this testing becomes pretty ubiquitous. I think many of us feel that in the next 10, 20 years, almost everybody will have their genome sequence as part of their routine care. So it's going to behoove clinicians and the educators, medical schools, to be training all clinicians to be comfortable in not only telling families and explaining results to families, but being able to look at the sequence probably and see how it impacts their patients. So it's going to be a big iterative process for the medical profession and clinicians before we can really expect families and lay people to understand and appreciate some of these subtleties.
Dr. Bodamer, if we're talking about big picture, how can we integrate genomic data with existing healthcare systems to sort of reach, maybe full clinical utility or access of that data to those primary care physicians or other specialists?
Yeah.
And sort of what role do you see standards playing in that approach?
There was a recent paper published in Genetics in Medicine, I believe, at the beginning of the year, by about the Penn Chart initiative at University of Pennsylvania, Penn Medicine, and what they demonstrated was a two-staged approach to integrate germline and somatic genetic data into their EHR, I think, which was based on EPIC, if I remember correctly. And they actually went as far as integrated in a way that they made sure that the genetic test results were no longer uploaded as a PDF. They made sure they were uploaded as a real data set. And they highlighted the genetic test results in a centralized location, accessible to providers in that healthcare system, to allow, I think, electronic searching. They allowed clinical decision-making, clinical decision support. And they also allowed that to be linked with educational activities that would provide almost an automated point of care education. So when a provider would see a patient with a certain genetic test result, treatment recommendation would be associated with that. Very important, obviously, for example, for pharmacogenomic variants. I think this is a nice example that kind of underscores the utility of a full integration of genetic data into an EHR system. And obviously, coming back to the question of standardized vocabulary, obviously that plays an important role, that the data format have to be standardized, which in addition also lends a utility for research, because you could retrieve those data, reanalyze the data. So I think that's a very nice example. It was published, I believe, earlier this year.
Dr. Krantz?
Yeah, no, I don't have too much more to add. I think it definitely, these genetic and genomic tests are unique, but they're unique in the sense that they're not static tests, and they need to be integrated into the EHR to be portable and longitudinal. And I think everything Dr. Bodamer said is correct. And it's actually another point, getting back to panels versus exomes and genomes. Panels are great on some levels, but the advantage of an exome or a genome or a slice that has an exome or genome base is the sort of live nature of that test and ability to go back and requery and to have that information and that data as more knowledge is garnered. But I think unless those tests are able to be integrated in a meaningful way into the patient's EHR and be portable wherever that patient is receiving their care, and longitudinal in terms of being reevaluated and reassessed, you know, the issues for a 5-year-old are very different than for a 65-year-old. And the amount of knowledge that will be gained in those 60 years also is tremendous. So, so those are the key, I think, factors that have to allow integration of this data for real meaningful care, meaningful genomic care.
How would you sort of balance the sort of like the clinical utility of that data, you know, integrated within these healthcare systems over perhaps, you know, either privacy or ethical and legal concerns when it comes to mind, what come to mind in terms of unlocking maybe other potentials of whole genome sequencing going forward? Maybe Dr. Larson can take that.
Yeah, I mean, there's definitely a trade-off there, which we all recognize. You know, I think that there are, you know, of the data that's generated by whole genome sequencing or whole exome sequencing, or even a genotyping chip, right? There's some fraction of that data is actionable independent of context. So there are variants that we know enough about that they can drive decision support within the EHR, and there are health systems that have worked on that. A lot of those variants are relatively common in the population, and I say relatively common in the context of rare disease. But those are pretty on par with other types of health information. It's the more kind of the aspects of the genomic data that are kind of need to be applied in a bespoke way. That's the province of medical genetics, much rarer variants, things that are more private. And So, there's different types of data there. It's not a monolithic data set in terms of what you can get out of that genome level data.
I think so. I think we'll jump into some of the questions that have been coming in from our audience now for the next few minutes. We'll open it up so that everybody can comment on these. One of the questions is, what about the strategy of panel if panel negative reflex to whole genome sequencing? I guess given the information of structural variants and deep intronic regions, I guess those being available in the whole genome sequencing. Maybe Dr. Krantz can start with that.
Sure. Well, I think that's sort of been the standard approach up until more recent times. So again, panel testing definitely has a place in terms of eliminating maybe a certain number of VUSs or incidental findings, being very focused. So if you look at sort of an epilepsy panel, there might be genes on that panel that have some quirks to them or pseudogenes that are addressed specifically in a panel that aren't as easily addressed in a whole genome or exome. I think as whole exomes and genomes have gotten better, that many studies have shown that the exome level testing is equivalent to panel testing and has the advantage of more readily being updated with novel genes or surprises. So there are often cases, especially in young children or infants, where they may have hearing loss, but you don't appreciate a broader phenotype where it may not be picked up on a targeted hearing loss panel, but maybe on an exome. And I think as cost has come down, it's also been more efficacious to just go to the exome or the genome, and rather than doing like an array and a panel and then when everything's negative. But I think it's still sort of standard of care now to do the panels first and then think about exomes or genomes, at least as far as insurance companies are concerned. So it's a viable option. I just think that we're rapidly moving towards a exome or genome first approach.
Yeah, one of the things I'll add is that there are a lot of sponsored panels. So either kind of disease advocacy groups or pharmaceutical companies have made the decision to shoulder the financial burden of panels for their specific disease or phenotype of interest. And so, there's a lot of panel testing that we can get done without ever having to involve insurance. So retinopathy, there's a sponsored panel, skeletal dysplasia, neuromuscular, hepatopathy, seizures, that covers a lot of the patients that get referred to us. And if we can just take the insurance piece out of the picture, that is so big for accessibility and just getting that test done, getting a result in a couple weeks on that panel. Like for the retinopathy panel, that panel encompasses a very large fraction of the potential diagnoses that we could make. So that's a really, really reasonable thing to do, is to send a panel for that indication.
Dr. Bodamer, would you like to comment on that, or we can move on?
No, I wholeheartedly agree. I mean, it's I think what Dr. Krantz said, it's slowly but steadily moving in the direction of exome and genome sequencing. And what Dr. Larson said, absolutely. I mean, these panels are readily available and very useful because there's no insurance piece attached to them.
We do have a sort of a follow-up comment from the gentleman who asked that question. So he says, yes, but they are isolated panels run on specialized platforms in most cases. And if you, I guess, end up with a negative, you are at a dead end. Any comments on that?
Yeah, I mean, free is free and you get what you pay for sometimes. So yeah, there are limitations to some of those approaches, and clearly it's not a sustainable model. So they may exist for a few years where you can get those done and they may go away. But for families where it's not economically feasible to do an exome or even a panel, having those options have been a tremendous benefit.
Next question also ties in well to some of the discussions we've had, but we didn't touch on this topic. do you think there is a space for preventative or asymptomatic whole genome sequencing? I guess 4 panels, but we can answer the whole genome sequencing sort of angle first.
Yeah, I think there is, but it's important to consider the risk-benefit ratio. So, if you're caring for a patient with a rapidly progressive neurologic disease, you send a whole genome sequence, the odds of that patient being harmed by you not sending the test are so much higher than the odds of them being harmed by you returning an uncertain result. But the calculus is very different for an asymptomatic person, right? The potential for harm from uncertain results is higher, and the potential for benefit is lower. So the threshold of certainty above which you would relay information to the patient is very different in the asymptomatic setting versus a symptomatic individual.
This is like a topic that I think PhenoTips can do a whole webinar on separately, because it's a very exciting area. What is preventative medicine? And I think that's where we're going. I love the idea, as we get more comfortable with the data and the analysis, to have every newborn to have a newborn screen where we're hopefully maintaining health and not just doing it diagnostically for symptoms that are being seen. We do it for newborn screening for metabolic conditions. Is a much more simpler way of looking at it. I think genome sequencing in newborns can address a lot of medical issues that there are some treatments for prevention in that sense, but also in terms of pharmacogenomics, and as patients age, as we start to develop therapies for Alzheimer's and different later onset disorders that may have to be started pre-symptomatically, I think there will be an important space for getting this sequence early and instituting preventative medicine. I don't know if we're quite yet there. As Dr. Larson says, I think there can be a lot more anxiety and harm that can be generated from some of this data, and maybe not so many benefits and interventions, but we're getting there, and I think it is going to be an inevitability.
So another question we have from the audience is, how do you envision whole genome sequencing being used in diagnosis of complex diseases? Dr. Bodamer?
I think that's a difficult question to answer. I think we have good understanding of some complex disorders and genetic susceptibility factors, but I think in many ways we're only scratching the surface. I think whole genome sequencing will eventually be of benefit for those complex disorders where there is a clear understanding of the underlying mechanism and probabilistic value of identifying a variant in a gene that increases susceptibility. I mean, one example is hemochromatosis, for example, where there are variants that increase the likelihood of manifesting disease if a pathogenic variant, for example, is present in trends. So I think the answer would be maybe not immediately, but certainly in the future.
Yeah, I think to me, it's a little catch-22 situation, which gets back to what Dr. Bodamer said. If we went to a more broad-scale universal screening using genome sequencing, and we had a centralized database and we had 100 million genomes that we were following longitudinally, we may get more answers for complex traits and understand more of the genetic contribution and potential intervention. So the approach might satisfy the end means in the end, but I don't think we're quite there yet again.
I think one other thing to think about is, at some point, we define complex disease, and at some point in that spectrum of complex disease, you're in an unusual enough clinical situation that it's worth testing for rare disease, for monogenic disease. So the example might be myocardial infarction. So if that happens in a 60-year-old man, the yield of genetic testing is very low. If it happens in a 20-year-old woman, the yield of genetic testing is very high. And somewhere along that spectrum is a crossover point where the yield is low enough that it doesn't justify that use of resources in the current environment. But that's going to change over time. And there are some fraction of people who look for all the world like complex disease that actually have a monogenic disease. And picking those people out is important from a management perspective, but it's just a question of resource utilization. How much resources is it appropriate to use to pick out that small fraction of people?
Some of the complexity similar to what you were just talking about, Larson, on the other side of the coin is people are realizing now as populations get sequenced that there are known pathogenic changes in monogenetic disorders like NF1 where the individuals have no symptoms. So you can imagine the amount of anxiety and distress that would cause for a newborn who is getting this as a tool to use for preventative medicine, and the amount of maybe clinical resources and things that would be used unnecessarily in a patient like, with a NF1 mutation that may never manifest symptoms.
Another question to the panel: how does whole genome sequencing impact treatment options for patients, I guess, in comparison to other tests? And has that changed in the last few years?
I mean, maybe I can kind of take a stab at this question. I mean, based on our experience with Exome, it certainly has accelerated the accelerated earlier diagnosis, more timely diagnosis, and allowed patients to be treated more in a more timely fashion, given the kind of the broader spectrum of diagnosis we cover. And I think that's important to keep that in mind when it comes to variant interpretation. That kind of availability of treatment is an important aspect. And I think there's still a fairly small number of genetic disorders that are truly treatable in the strictest sense of the word, but I think that number keeps increasing. And I think these are the patients that we should not only miss a diagnosis, we certainly shouldn't miss a treatable diagnosis. And I would expect that Genome would further accelerate that.
Dr. Larson, maybe the next question to you. What steps do you think can be taken to improve, I guess, diversity in populations used in genetic studies? And how can we make sort of access to genetics, more widely available to people in various groups or even geographies?
Yeah, so I think those are two separate questions. On the question of the participants in research studies that contribute to both understanding the genetic landscape of phenotypically normal adults, and also understanding the genetic landscape of people with a specific phenotype, we have already established that there is significant benefit from increasing the diversity of populations that have access to be participants in those types of studies. So that was touched on really nicely in the suite of papers from the Nomad group last year, and just in terms of how much benefit there would be per additional individual added to Nomad with an African genetic ancestry as opposed to a European genetic ancestry. There's no doubt that there would be significant benefit in that arena of increased diversity and access to research participation. On the topic of utilization, so I think the second piece was sort of clinical implementation of testing in sort of resource poor settings or things like that. I mean, the thing that we need to do is to continue on the trajectory that we're on. Just to take a very, very kind of mundane logistical piece of this, the fact that we can do testing on buccal swabs has just dramatically increased the access to testing. I mean, there are patients that I care for where just getting phlebotomy is enough of a barrier that it doesn't happen. So sample types, I think the interface between health systems and payers and labs and clinicians, there's, as we've talked about a lot, there's a lot of work to be done there in terms of increasing access. And I think that the benefit of testing per person tested is going to be higher in those populations that have less access to care. For the reason that I talked about earlier, those are the folks that don't have access to the experts who have the experience to make the clinical diagnosis. And that broad testing can really act as a safety net. So I feel strongly about implementation in resource poor settings of broad testing.
Dr. Krantz or Dr. Bodamer, would you like to comment on that as well?
I would agree with that. I think that what we need to do is diversify the providers as well. And that goes back to the pipeline, probably back to middle school and high school education through undergraduate and medical school and residency. I think genetics is complicated because we're small in numbers, but I think in this new era, everyone needs to be educated about genetics and genomics, but I think we really need to have providers that reflect the diversity of our population and internationally, and we're just not there yet with our small numbers. And I think we need to take an educational approach to go back along the pipeline and excite people about genetics and genomics, and do everything we can to increase diversity amongst us, the providers.
It's certainly a multifactorial approach, and I think one that we've spoken about before on previous webinars as well is including sort of genetics-based education for physicians being currently trained, not necessarily in genetics, but in other specialties, and sort of how do you increase that understanding of genetic testing and genetics across clinicians coming through the med school system. Perhaps one more question before we sign off. How do you foresee these whole genome sequencing projects playing a role in therapeutic and drug discovery? Who would like to take that on?
I can take a stab at it, although Dr. Bodamer may be more appropriate, but it is the first step towards that. So I kind of, what we went through, if you look about the field of genetics over the last 20 or 30 years, even since I came into the field, there were just a handful of tests that we had. We didn't understand anything about disease. And we went through the last 20 years or so, mostly focused on gene discovery. And now we're transitioning more towards functional genomics and how do we leverage what we know for both small molecule therapy as well as gene therapy. And I feel that the tools are now available to really, capitalize on that and leverage therapeutics. And I think the landscape is definitely changing. And I think the future, when I talk to families, I'm very optimistic of what's going to happen over the next 10 and 20 years in terms of precision medicine and medicines that target individual genes or changes within those genes. Again, for me, it's building a pipeline in education. I feel like for many of us who've been in this field for a long time, we were gene discoverers. We had to spend 10, 20 years collecting cohorts and getting intimately involved with families and understanding the diagnosis. And when we finally found a gene, we were hooked, and we're passionate about that diagnosis and passionate about helping those families and those kids. Our trainees nowadays, most of them come out of their training with a diagnosis named after them because they did an exome on a family, they found an interesting case, they put it in Gene Matcher, they found 3 or 4 other cases, they reported it, and they move on. What we have to do is really engage biologists and our trainees, our residents and physicians to really dedicate themselves to these individual diagnoses and working beyond gene discovery towards, improving the lives of these families through, new therapeutics and management options.
Dr. Bodamer, would you like the final word?
Yeah, I feel that whole genome and evaluating its value for therapeutics should not be seen in isolation. I think whole genome really adds its value in concert with the other omics technologies. I mean, transcriptome, for example, methylome, proteome. I think everything seen kind of in synergy, that's where I would feel therapeutics will have we will see the biggest impact on therapeutic development.
Mm-hmm.
Do you mind if I just add a couple more thoughts?
Yeah.
So, I mean, I think one piece is making sure that you're targeting the right population. So clinical trials that require a definitive genetic diagnosis of a specific disease as opposed to a clinical suspicion of a disease, that's a very different ascertainment, and you get different results if you're targeting your intervention more appropriately. I think the other thing is to think about mutation-specific treatments at the level of the DNA, at the level of the RNA, at the level of the protein. We have examples of all of those, like splice-altering custom antisense oligonucleotides, which Dr. Bodamer and I have both had cases in common in that scenario. CFTR therapies that are specific to a genotype that operate at the level of the protein. So all those things are really critical in terms of making our therapies really targeted and really disease modifying at the level of the actual mechanism of disease.
Mm-hmm. So it's certainly been very, very insightful discussion. We probably could have gone much deeper into many of the topics we covered today. I want to thank you for joining us, both you, the panelists, and our audience. Once the webinar ends, you'll receive a feedback link in your browser. So please take a few minutes just to offer feedback on this episode of the webinar. You'll also receive an email after the webinar concludes with a link to the PhenoTips Speaker Series page, where you can sign up and receive alerts on upcoming sessions or find out how you can stream past installments on demand. The next webinar will be happening in November. Those details of that November webinar will be shared and available in the next week or so. And once again, a big thank you to Drs. Bodamer, Krantz, and Larson for joining us today, and for everyone else for tuning in. Take care.